Welcome to another episode of Reboot with Dr. Arasi Maran. I'm your host, Dr. Arasi Maran. I'm an interventional cardiologist and I'm also an associate professor at the Medical University of South Carolina. But this initiative is completely separate from my duties as a faculty at the Medical University. Today, I have a very special guest with me, Dr. Sharee Wright. Dr. Wright and I go a long way. We have worked together for several years. She is also an associate professor of surgery. She's a vascular surgeon who specializes in all aspects of vascular and endovascular surgery. She focuses on diabetic limb salvage, aortoiliac disease, and aortic aneurysms and carotid disease. She is originally from the Low Country, Charleston area. She was in private practice, then came back to Charleston and has been working with us for several years. Welcome to the show, Dr. Wright. How are you doing?
I'm good. Thank you for having me. I think this is amazing to be a part of, particularly as you said, we go back a long way. So you've got two women who delved into the world of piping and plumbing of the vascular system, trained together, and here we are discussing this again. So thank you for having me.
Absolutely. So since the name of the podcast is Reboot with Dr. Arasi Maran, I want to see if you have a story you can share with us about where you rebooted your life and why you did and what were the reasons you did.
So one that comes to mind is I initially finished training and I went into non-academic medicine where I was essentially in private practice. And as much as I told myself that that's where I needed and wanted to be, I found myself doing a whole lot of teaching to people that may not have been receptive to it, and that's definitely people that were receptive to it. So that drive to kind of teach my patients and to teach students and trainees was still there, and I kind of picked everything back up, started over, and went down the academic journey and joined an academic practice, which is where I am now.
Fantastic. The teaching never stops, right? Wherever you go, whether it's the hospital or clinic, we're always teaching someone something about the health or whatever the procedure we are doing.
Yeah, it's a constant thing.
So, everyone knows about blockages in the blood vessels of the heart, but I feel like people are not very aware that the same type of blockages can occur in other parts of the body, especially the legs. Can you talk about peripheral arterial disease and what does it all encompass?
That's a great thing, a great topic to bring up, a great question, because you're right. A lot of people, they know about, like you said, blockages in their heart. They seem to grasp that concept really well. And the way I explain it to my patients is like, essentially vascular disease is organized chaos. It's the same processes that cause those blockages in the heart are affecting all the other blood vessels in your body. And the ones in your legs or even your arms that are considered peripheral arterial disease can present in a bunch of different ways that as a normal person, you would think like, oh, maybe I just did too much today. Let me fix it myself. Let me rest. And that's your body's way of saying like, there's a problem going on here. So when I talk to patients, when I teach my students, I tell them the same way heart blockages lead to a heart attack, that's that heart muscle screaming for energy, screaming for blood volume. When your legs are cramping when you walk, that's your leg muscles. They're screaming for energy. They're screaming for volume. The flow can't get there. And kind of breaking it down into those little simple concepts, you can see like the understanding start to happen on people immediately. And then you can start to build on that conversation to tell them other things they can look for and how it affects their overall life.
Absolutely. So before we go into the symptoms, can you tell us what are the risk factors for blockages to the blood vessels in the leg?
So one of the main things, smoking is definitely a huge risk factor, and it's a lot of the chemicals and things in cigarettes will cause those blood vessels to kind of constrict and narrow on themselves. I tell people is all the things that we do when we're in our like teens and 20s when we think we're invincible. We can, eat bad, the midnight chicken sandwiches from McDonald's with French fries and milkshakes. You wake up and go, and you don't really focus on exercise and taking care of yourself. That all comes back, kind of bites you in the butt when you're in like your 30s and 40s. So that process starts really early on. And I think having those like healthy lifestyle choices and healthy life decisions early on will kind of prevent that from propagating to something that's really severe. There's also a family history. So you start talking and you realize like everybody in your family has had a heart attack, or someone's had their leg amputated, or someone's been on dialysis. All of these factors play into your overall arterial health. And we can't, ignore the effect of food and what we eat and the types of food that we eat, how that plays. So a healthy diet. I am a big cookie fanatic. I love a good cookie. But I know I can't have a cookie every day for every meal of the day. So there are things in moderation that we can do. Healthy weight, so mitigating obesity, all of those things those are the risk factors that make me start thinking I need to check this person's legs, feet, arms, and make sure that the blood flow is doing what it should do.
So, it's pretty much, it seems like, because this is all a cardiometabolic disease, diet and exercising and maintaining a healthy weight and quitting smoking, it all comes into place. But you didn't talk about vaping. Does vaping have the same effect on the blood vessels of the arms and legs like smoking does?
I believe so. I think it does. And in itself, it does. While people are like, well, there's no nicotine in it, it's healthier for me. It's not. There are other toxic chemicals that are mimicking what the cigarettes are doing. And with vaping, I tell people it's also a way that is going to lead you back to smoking because you're not kind of ceasing the habit of what caused you to pick up the cigarette in the first place. It's kind of getting out of that routine and breaking that habit is the best thing for you. So I'm a big proponent of no smoking, no vaping.
Yes. So can you talk about, you briefly touched upon smoking and nicotine or the other chemicals. What does nicotine exactly do? How does nicotine affect the blood vessels?
And so when I talk to people, I try to tell them, it's hard to go through and say this chemical compound attaches to this and causes that. What it does is, like I said, there's already some layering of disease in your blood vessels that's making it more narrow than it was initially. And these toxins from the cigarette smoke, from the vaping, it causes them to spasm. It's essentially like the whole blood vessel sucking in. And so now even less blood flow is getting through there. So the walls of these vessels are now stuck together, and it's really hard to pop them back open, so to speak. And your body just starts building on all those diseased area, and eventually your 4-lane highway on the interstate has turned into a single road, like, dirt road going to a neighborhood, and just it can't keep up with all the blood that your body needs to get to those places.
Now, are there any gender differences with smoking between men and women?
So with women, we have found, and there are a lot of studies that address this, that they present earlier with peripheral arterial disease. And there's some thought that they have smaller vessels or they're affected more. But even when you kind of account for socioeconomic status, health status, diet status, the women tend to present with disease that are far more advanced, and there's little that we can do earlier with them than with men. And I think it's kind of similar with heart disease as well. While the classic symptoms and the classic teachings in the books are chest pain, my jaw hurts, my arm hurts, women tend to have like, I got a little bit of epigastric pain, or, it feels like I got a bad heartburn. So by the time they show up, it's like, really, the cat's, everything's out of the gate. And the same thing applies for peripheral arterial disease. So it's a lot of kicking the can down the road, for lack of a better analogy, since we're talking about legs. But they keep progressing and progressing. And finally, when they present, we see such extensive disease that there's very little we can do outside of major vascular surgery.
I keep telling my patients, smoking is bad for everyone, but it is even more worse for women, because I just feel like women's blood vessel, the endothelial cells, just does not like the nicotine exposure or all the other chemicals with it. And it's like a forest fire almost. It just shuts down everything. And sometimes the blood vessels, especially in the heart, becomes too small, and we are not able to put any stents in them because they're just too small for us to treat. Do you see something similar happening in the legs and arms too?
Very much so. And it's not only like it's too small to put a balloon in or a stent in, it's more so when even we go to do like an open surgical bypass, the vessels are too small to even accommodate what we're doing. And so for vascular surgeons, when we do bypasses to the legs, we have to go from a good artery, kind of build around the bad artery and attach to another good artery. Mm-hmm. So it's like building a loop around the interstate. So you take 526 instead of going straight down 26. And if I don't have a good road to end to, then my bypass isn't going to stay open. And in our female patients, particularly with such advanced disease, that's where we see the problem. It's not so much we can't get balloons and wires, it's just that all the blood vessels past the disease are also really small in disease. So it limits how much we can do and how we can help.
Now, what happens if these patients are also diabetic? How does it affect the process?
I'm glad you brought that up because I don't think I mentioned that when I was talking about the risk factors, but diabetes is a huge risk factor because not only does it damage the blood vessels, it also makes them really hard. And so your blood vessels normally are pretty muscular and pretty floppy, like maybe slightly overcooked penne pasta, like you can still squish it between your fingers. And so when you get diabetes, it starts to harden the whole inside of the vessel. So it turns into like a raw pasta noodle. You can't squeeze it. And if your blood vessels can't squeeze, they can't push the blood flow down to where it needs to go. And so you tack on the narrowing and then the hard vessels. I can't make an incision in it. I can't cut it. I can't clamp it. Anything we do to those blood vessels ends up damaging it more. So we're really kind of limited in what we do, which is why we try to not force, but we try to push educating early on. Like, here are the things that you need to look out for. This is when you need to come see us because there's so much more we can do earlier on to kind of prevent getting to those end stages.
I'm sure the same thing happens with high blood pressure too, right? The blood vessels become hard and you're stuck like that. Now, what symptoms, you kind of mentioned a few of the cramping, like what symptoms should be looking out for?
So the earliest symptoms that people will have is that your legs start to hurt when you're walking or doing your normal activities. And I ask people all the time, like, how many aisles of a grocery store are you able to walk before you feel pain? When it's primarily an artery problem, what happens is that same distance each time. You can walk 2 aisles and your calves will cramp. You stop for 2 minutes, it gets better. You walk another 2 aisles, your calf cramp, stop for 2 minutes, it gets better. It's pretty consistent. And that immediately gets us to thinking there's a blockage somewhere. And the next step is you tell your doctor, and the next thing they should do is take their little fingers and put it on your feet to see if they can feel the blood flow with their fingers. And that starts a process of getting you referred to the right person to do further testing to see just how much blood flow is leaving your heart and making it all the way down to your toes. Now, some people, have to take into account that not everybody's walking through a grocery store, right? So not everybody can make it through an aisle of a grocery store. So other symptoms that people need to look out for to kind of suggest that you've got arterial disease is there's usually some swelling of your legs, kind of from the knee down to the ankle. The lack of hair, when your leg starts to get a little shiny and all the hair kind of goes off of it, that's a big sign. If you're having pain across the top of your foot into your toes when you're laying flat in bed, that's a huge red flag that you need to get checked out. And then, of course, there's the dark discoloration of the legs or any kind of wound on your fingers or toes that's not healing in a normal amount of time. Everybody gets cuts and scrapes and scratches, and you get a scab and it's gone in a week. If you look down and all of a sudden that cut is still there after several weeks, then you need to get that checked out, particularly for our diabetic patients and our patients with kidney failure or kidney disease or patients with elevated blood pressure.
So, in diabetic patients, they normally should have their feet checked specifically for this reason, right? Because they can have blockages in the blood vessels of the legs and it can go unnoticed.
Yes. So every diabetic visit, like when you see your primary or even when you see your podiatrist, you should have a vascular exam. Someone should try to feel the pulses in your foot. And if they can't, then you are at risk for PAD. So I always recommend that we do a screening test, which is essentially a blood pressure cuff on your ankle and one on your arms. And we match the pressures to see if we can get a percentage of blood flow going down there. So at the very least, that for our diabetic patients, I definitely recommend it yearly. But all the risk factors that we talked about earlier, the high blood pressure, the cholesterol, the smoking status, even if you quit, all of that puts you at risk. And those risk factors by themselves should get you a screening exam, a foot exam, a clinical exam by your primary or specialist, and that test to check the blood flow going down into your feet.
So let's say they do the test and they come to you. I'm sure, like everything in medicine, there's a mild, moderate, severe
Yep.
classification. So, what if I have mild disease? What can I do? Can I to make it better without having to be get stents and things like that?
So everyone thinks, you hear surgeon, and it's like 50% of the time people come into clinic thinking I'm going to cut them right then and there, and I'm like, no, that's too barbaric. So you're right. There's mild, there's moderate, there's severe disease, and so for even our mild and moderate patients, there's so many things we do before we get to that point of saying we need to do something invasive. So we always start by first educating you on what's going on. I like for my patients to know what I know. Here's what's happening with your blood vessels. Here's how we can fix it. The second thing is we do a lot of lifestyle modifications. So if you're a current smoker, you got to stop. And it seems harsh, but I tell patients like every cigarette you pick up is one toe that you might lose. And sometimes hearing it in that like direct manner is enough to make you say, these cigarettes are not worth it. So you've got to stop smoking. We also take into account like what your diet is. We check your cholesterol levels. We make sure your blood pressure is controlled. If you're diabetic, we make sure that your A1C levels are normal and within range. We want your blood sugars controlled. If you're obese, we give you a walking program to like start getting the weight down. All of these factors will help keep the disease process where it is. And our goal isn't to make it go back to perfect. I'll never be able to give you the legs you had when you were 18, but it stops the progression from mild, moderate into severe.
So, what is the percentage of success with lifestyle modification?
So that all depends on how you present us. If if you're in that mild to moderate range, the chances of you progressing to needing any kind of surgery or any kind of intervention is less than 20%. So with lifestyle modification and surveillance, we have up to 80 to 85% chance of you never needing anything. Again, it seems silly because we're surgeons. We like to do operations. We want to do these procedures. But I know that once we start messing with those blood vessels, then the risk of having to mess with them more and more goes up. So our job is to prevent the progression of this process over the course of time so that you don't need a surgery and you don't need to have a procedure until it's absolutely necessary.
I think you bring up a very good point. A lot of time, there's a lot of distrust or mistrust with doctors, whether it's interventional cardiologists or surgeons of any kind, that patients sometimes think I'm going to go to them and they're going to ask me to do something invasive and I'm going to lose something. But most of the time we tell them, we can fix this if you can do some lifestyle changes. There are patients who are very happy with it. And I'm sure there are patients who are very disappointed that you're not doing something to fix them right then and there.
That's true. Like I said, a lot of people come in thinking they're getting a surgery right then and there. And it's a lot of what they know, what they heard, or someone else's narrative about what happened to them. And I think our job as a physician, as the provider, is to educate and say, okay, well, yes, I know someone in your community may have ended up with this big surgery, but that's because they came in too late or they came in with a different disease process. Again, I take it all back to the organized chaos. It's the same process across the board, but it presents in so many different ways that your treatment plan is ultimately individualized. And I think honing in on like letting them know, like if you needed a surgery, if you needed a procedure, we're there. We're definitely going to be the ones to do it for you. But here are some things that we do ahead of time to make sure that it's not going to be a problem down the road.
See, I mean, the symptoms are cramping, and cramping can happen because of so many reasons. You have muscle cramps because, you don't exercise a whole lot, or you can get nerve problems, you can get back problems. How do you tease that out? Or how does a patient think whether this is my muscle or my nerve or my blood vessel?
That's a hard one because there are so many things that present very similarly. For example, people with lower back problem have the same exact symptoms as an artery blockage in their legs. They walk and their legs hurt and they stop and it gets better. I think the main thing that I get across to patients is I don't need them to come in and try to differentiate whether or not it's their back or their arteries. I just need them to be comfortable enough saying, my legs hurt when I walk. So many of us self-medicate or like self-treat and self-diagnose. Like, I'm guilty of it too. I operate all day and I get home and I'm like, oh, my legs are cramping. Let me put my legs up, right? So if you have a job or you did a lot and you're like, my legs hurt, I think I might have slipped or tripped on a sidewalk, or I just did too much today, you're going to take a couple of days to try and treat yourself. But it's knowing that when these symptoms persist and when they're consistent, you have to seek expert opinion from someone. Your primary care provider or specialist, the ER, is just, you have to have someone check it out, particularly if you have those risk factors. And I think educating patients and tying it in together, where it's like, my legs hurt when I walk around this store. By the way, I'm a smoker and I'm diabetic. You're at a higher risk than the 16-year-old who legs hurt after playing like 4 hours worth of soccer. So it's kind of knowing when to seek help. And that's what I try to get across to people. I mean, if patients come in and say, I know this isn't my lower back because it's a different kind of pain, I'm going to be impressed, but I'm still going to go through the same workup.
Most of my patients who come to the hospital with heart attack, when you ask them, how are you feeling 2 weeks ago or 3 weeks ago? They're like, yes, I do remember I was slowing down. And every time I walk across a block, we use a block, you're using an aisle. I walk across a block and I have to stop and catch my breath, or have to wait for the burning sensation to go away. And I was like, that's your heart. It's not, it's not anything else. So I think it is really important to be mindful. And that's the whole point of this podcast, is to kind of help improve or increase health literacy among our patient population. Now, what are the treatment options available?
So if we are, let's say we do the lifestyle modifications and medication management and we're still having the symptoms and it's gotten to the point where it's interfering with your daily life, it's interfering with your ability to do your job, or, if you're in that severe category, we have different treatments that we offer based on how you present and what your disease looks like. A lot of the things that we do in peripheral arterial disease is very similar to what we do up in the heart, or what you do up in the heart. They don't want me up there. And so we could do a lot of interventions in a minimally invasive fashion. And it's just like a heart cath. There's a needle that goes into the groin, and we can put wires in there, and we can do ballooning. And then if we need to, we can leave stents. We can kind of clear the plaque out if we need to. So we have a bunch of different tools that we can go in and kind of recreate or open that artery back up to get it as close to 100% as possible, but definitely better. If for some reason, like, we can't do anything with wires or we can't do anything with stents, we still have the option of doing like a surgical bypass, which is that rerouting procedure. I hook in from a good artery, go around the blockage, and then hook into an artery again. So there's a range of different things that we can do to kind of get your pain and get the symptom better.
A lot of the procedures we do for the heart blood vessels, we kind of learned from you guys, the endovascular and vascular guys, especially the 100% blockages. In the past, when patients had 100% blockages of the blood vessels of the heart, we just treated them with medications. But as the endovascular, you guys started fixing the blockages, we learned the same skill set applied to the heart, and now we treat the 100% blood vessel blockage invasively also. So, there's a lot of cross-pollination between our two ends. Now, when we talked about exercise, and you specifically mentioned a walking program, is walking the best exercise for someone with peripheral arterial disease, or should they be focusing on strength training? Is there a difference?
There's a difference. So walking is definitely the better thing. So what we're building is collateral circulation, which means all the smaller little arteries that are nearby, they start to beef up a lot when you're walking, because again, as you're moving, those muscles are saying, give me oxygen, give me blood, and your body's trying to get it there. When you do strength training, all you're really doing is like one burst of energy for a short period of time. And that's not really a lot to build those extra blood vessels. So the walking program is what we really hone in on and stress to patients. 3 times a week, 30 minutes a day. In a perfect world, it's a like supervised walking program, with someone monitoring you and changing the incline. But again, just like I recognize not everybody can walk through a grocery store, not everybody has access to that. So I try to make it as user friendly as possible. So for patients, I tell them just walk around your house or walk around your apartment complex and do a little each time and start building up your distance in increments. I tell you, walk till you feel the cramping pain in your calf, and then I want them to walk for 1 minute more and then turn around and come back. And then you just keep increasing that over time, and it kind of builds those extra little arteries to get the blood flow down to the muscles like they should.
That's pretty much what we do in cardiac rehab also. And some of my patients with the 100% blockages, the chronic total occlusions, I literally tell them the same thing. You're going to walk till your chest starts hurting. It's going to be okay. You just stop, take a few deep breaths. The pain will come down and you can walk more. Now, again, going back to the exercise program, how about high intensity training? Does it help them to walk really fast and really slow? Does alternating their speeds between fast and low make a difference?
Not for the legs, and I try to caution against that just because I want them to start off slow and build up. And a lot of times it's kind of like if I decide I'm going to run a marathon next week and I train, 2 days in the middle of the week and said I'm ready. I'm coming out the gate hot, but at some point it's going to be too much. And then for 2 days later, I'm just laying around really cramped up. So small little increments also kind of increases the level of success with the program, and you start noticing a difference more. It's easier to manage. It's easier for patients to understand. If they get to the point where they're able to do some more high intensity things, then I encourage them to do so, but we always start off pretty slow.
Okay. Now, we talked about smoking as a major risk factor. What happens, let's say the patient comes to you, they get really scared by what Dr. Wright has told them. They stop their smoking, you do their treatment for them. And what if they come back to restart smoking? Does the disease accelerate? Does it stabilize because of what you've done? How does smoking affect the treatment you have done?
So there's definitely a correlation between smoking and recurrence of disease. So I can go in and those 100% complete blockages that you talked about, we can do all this therapy, open them up either with a stent or even if I do a bypass. As soon as you start smoking again, it starts the process over and it accelerates the time that those things start to narrow again. So then it kind of puts you back to where you were prior to me doing anything at all.
Oh my God. Seems like smoking is such it's really, really terrible for the blood vessels of the leg.
It's
And
horrible.
people
I
don't
tell
seem to
everybody.
understand. Yeah, it's please believe me. I just if there's one thing, tobacco addiction is such a terrible, terrible addiction. It's so hard, and it's still available after all these years of us telling us it's bad and it's bad. The tobacco industry is still flourishing, and they're still making profits at the expense of all our patients. And it's most of the time the lower socioeconomic status patients, the patients, the minority patients who are, working day jobs and truck drivers and who are already sedentary and things like that. So it's just a vicious cycle, and the government, the regulation departments are not helping us a whole lot, unfortunately.
It is. It's really hard just because it's so accessible, like you said, and there's there's negative connotation to it from the medical perspective. And I will preach all day, every day, over and over how bad cigarettes are. But if you think about it, you don't smoke a cigarette and you're stumbling around like you were drunk. You don't smoke a cigarette and lose the ability to function as if you were on any other drug. So that's what makes it really hard for people to kick that habit. And it becomes so routine. It's an accessible, legal, routine for you to do. Have a cup of coffee, smoke a cigarette. Lunch, go out, smoke a cigarette. After dinner, you're going to smoke a cigarette. But I keep trying, and I will continue to keep preaching how detrimental it is to everything, every blood vessel in your body, your skin, everything is affected by cigarette smoke.
I mean, even for us, when we have patients we put a stent in and they get excessive scar tissue. And if they're also smokers, they just keep coming back and coming back. And we are like, unless you stop smoking, this process is not going to stop at all. And like dental cleaning, we will be ballooning the blood vessels of your heart every 6 months. And there's a 1 in 1,000 chance of a major complication, including death. And do you want to put yourself through this every 6 months for the sake of the cigarette, but even then it's so hard. And, it's such a big, it's a burden for them, and the cigarettes are everywhere in every store. So it's just not, it's just too much for them also, to be addicted to it for so long. And they just don't seem to care about, or they want to ignore or put blinders in their eyes when it comes to this process. So you talked about diabetes. Now, there's a whole lot of new generation of the GLP-1 agonists. Has that affected your practice at all with regards to blockages to the blood vessels of the legs and arms?
I haven't seen a lot of changes just from the new medications. I do know, it is something that patients are using for weight loss, which is always a good thing. I will say one thing that I've noticed with these GLP agonists is that while they take away the drive to eat, they also take away the drive to drink. So there's a lot more dehydration, which can affect your kidney function, or it actually makes your blood a little thicker. So clotting along areas could factor in, but it hasn't really increased. And, it's early. This is a new thing that's been started and more people are on it. I haven't seen an increase in the rates of people being diagnosed with PAD or the amount of interventions that we're offering so far.
Because I was surprised because they have talked about improvement in cardiovascular outcomes. So the blockages are getting better. The heart failure rates, it seems to be really doing a fantastic job in that population, and even in kidney disease. But I haven't seen any studies come out about peripheral arterial disease. So I'm really curious to see how it affects that portion of it. Now, what about the drug-coated balloons? You guys have been in the blood vessels of the heart. FDA just approved for us very recently. But how about the legs? You guys have been, can you just talk a little bit about that?
So yeah, the balloons that we're talking about are the ones, so way back in the day when they first started putting balloons in legs, it was just that. There was a wire, there's a balloon, they blow it up, they shake your hand, you're good to go. And so what I tell people is like this balloon, what happens is it unfurls or opens up kind of like an umbrella and like a spiral pattern. And when we're doing this technique, what we're doing is essentially we're damaging the inside of the artery. We're kind of making these little tears, and your body wants to fix a little tear, and it makes clot and platelets and everything kind of gets stuck to it. So we came out with these balloons that kind of, when we blow them up, it deposits medicine in the areas where we've made the little tears to kind of keep the artery from clotting back on itself and keeps it open. We've been utilizing these for years. I think I remember doing them in fellowship, and they've been part of my practice since I've been out. And it has really advanced what we're doing, because prior to that, it was a simple balloon, and if it didn't look good, then you get a stent. And if the stent didn't take, then you get a bypass. So it just added a different layer and a different option for us, because there are certain parts of the arteries that we can't stent because it's too dangerous. There's too much bend, there's too much kinking, and it's risk for that stent to fracture. So these balloons are in perfect places that we can treat without having to worry about a stent. And you may see this as well in the cardiac world, in that there are areas where if I did a bypass where we cut that artery and we sew the graft on, or we sew the vein onto it, just like if I cut somebody's arm, you're going to make a little bit of a scar there. So that place where it's kind of sewn together can get a little bit tight, and these balloons are great to treat those areas. So you can see that, and that's a way to kind of salvage or maintain the openness of an artery after like an open heart bypass, because nobody's going to go redo your bypass, but you can go in and treat where everything's hooked up to make sure that the blood flow is still pumping.
That's very interesting. I think once again, we are borrowing technology from the legs into the heart. We are just getting, I think I used a couple of these balloons when I did cases in India. It's already approved in India, Asia market, and European markets. But in the US, it just got approved. And we'll hopefully get our first balloon later this year or something like that. Of observation for us, at least in the cardiology side, is we are noticing our patients are getting younger. Okay, They are coming with heart attacks and STEMIs and sudden cardiac death much earlier. No more the 55. 55 has almost become 50s, and sometimes in the 40s too. Is there a trend like that which you're noticing in the peripheral arterial world, or has it stayed stable?
No, I definitely have noticed a trend. I used to joke in fellowship, like when we had a patient that was in their 40s or, late 40s, early 50s, I was like, oh, we have a pediatric vascular patients because the thought is like vascular surgery is a more advanced elderly disease. But what we're seeing now is I have patients that are in their 30s, like you said, like early 40s, and they have really aggressive disease. And I think some of it is secondary to our diets, our exercise, our poor access to healthcare, not being able to recognize symptoms, not being able to be seen and get diagnosed with things. So you have a lot of the younger patients that have poorly controlled, like really aggressive diabetes that hasn't been managed for 10, 20 years. And you got to think if you're diabetic at 18, by the time you're 28, if it's not been managed, your body's functionally like a 58-year-old inside. And so we're seeing that patient population. And just because you present with those disease processes more advanced earlier doesn't mean that your life expectancy is lower. So now we're dealing with a 38-year-old that could potentially live to be 70 with these long-standing problems. So seeing kind of both as our interventional cardiologist friends, you're seeing people that you wouldn't think, like I have a 30-year-old on my table talking about doing a surgical bypass on or amputating toes or losing legs. And it's not things that we like to see, but we're trying to keep up with how do we prevent this young person from being on the table or get them in sooner. And I think access to care and things like that are the way to go.
So, there's definitely disparity within the cardiology population. Like, heart patients, minorities don't get the same amount of treatment. Women do not get the same amount of treatment. There's a big socioeconomic, gender, ethnicity disparity in the cardiology side. Does that reflect the same way in the peripheral vascular side as well?
100% is definitely there. There are several studies out where we've looked extensively at amputation rates between different patient populations. And for African American patients and Hispanic patients, they have like a twofold chance of our amputation rates when compared to the non-African American, non-Hispanic patients. And so many things factor into that. So you look at their socioeconomic status, you look at the areas where they live, you look at their access to healthcare, their access to healthy foods, and even when you eliminate the economic status, so you can also see this great disparity in amputation rates in minority patients that are affluent in comparison to non-minority patients, and they still get less treatment, less offering to non-invasive management, they get less recommendations for the lifestyle modification, they have twice as many amputations, and trying to tease out exactly why that is kind of where we are currently in vascular surgery because there's no real rationale as to why that should happen.
So, we do know the African American community are much at high risk for hypertension, and their hypertension works very differently from the non-African American community. So is the disease just more aggressive in the African American and Hispanic ethnicity, or you don't see? What do you think about that?
So I think is something completely separate. So, race is or ethnicity is like a social political construct. There's nothing like there's no genetic mutation that says like this is going to behave differently in this patient population. But I take it way back to kind of lifestyles in the past. Like if you think about the African American Hispanic communities and things that they have done to treat their own health because they were not allowed to go to certain doctors, because they were not given the priority of having adequate health care, there are a lot of things that are left over in the culture that can mitigate a lot of these disease processes. So then you go back to and say, what is it that we need to have in these communities to kind of stop this, right? So is it, again, I think access to healthcare, healthy foods, food deserts, and a lot of that is still going on currently where the communities that have the poorest access to farmers market, fresh fruits and vegetables, affordable healthcare are the ones that are heavily populated by these minority populations. And so in essence, they will, because of these factors, end up present a lot later with more advanced disease.
See, but if there's no genetic predisposition, we see a lot of genetic predisposition in the South Asian population because most of the South Asians are vegetarians. They may be drinking and smoking, but they are vegetarians. They are super thin. Most of them are not even obese, but their blood vessels are so heavily calcified and so heavily stiff. I mean, I'm sure, and they have smaller blood vessels because they don't have the same body mass index like the other people. So I find the South Asian population blood vessels to be one of the hardest blood vessels to treat. I'm like spending hours cleaning out the calcium buildup. And how do you see it in your side of the world?
Similarly, because they're the patients where I look and I'm like, you shouldn't have this. Like, why is this? And then so it does for me when we see it in the peripheral arterial aspect of things. I do engage a lot of other colleagues. So I start thinking, is there a rheumatologic factor involved? Like, so you see a lot of like lupus, Sjogren's syndrome, things like that people may not be aware that they have something that is causing these vessels to respond like that. But again, you're right. So there's just certain populations have certain things. And I'm like, South Asian or Asian American women, I'm like, this is, because every little thing you do is like, oh man, I fixed it. And then you look and you're like, I didn't fix it. And so it's just kind of like this propagation that is. So I usually try to find a way to get down to what the underlying etiology is so that we can kind of cease and desist, so to speak, and kind of make
Absolutely. I mean, I'm sure you agree with this analogy. I tell my patients, just because I've fixed the stent, I have not cured your coronary artery disease.
Yeah.
I have just fixed the problem right now, but the bigger disease is still at large, and you have to take care of yourself in other ways outside the hospital walls to kind of have a better health.
I do the same. I tell people, I'm like, this is a progressive disease. It's like, I fixed the problem that has presented today, but there are a ton more arteries in your body that can present tomorrow. It's the same with patients that have bariatric surgery. Like, you had your surgery today, but that doesn't mean you can eat a steak next week. Like, it's something that you have to maintain over the course of your lifetime to ensure you have like the most successful outcome.
Sharee, we are coming to the end of our show. If there are 5 things you want our patients or the audience to know, take away from this, what would those be?
Number 1, stop smoking. Don't start, stop smoking. Number 2, stop smoking and don't vape. Okay. 3, no, please talk to your providers, physicians, PCPs if something is persistent. Pain in your legs when you're walking a certain distance isn't normal. Get that checked out. 4, have someone check your feet. See if they need, every time you go to the doctor, everybody goes at least once a year for something. You need to check your feet. If they can't feel a pulse on your feet, you need to be seen by someone else. Number 5, lifestyle changes. We're not 18 anymore. We cannot have fried chicken sandwiches at 2 a.m. with milkshakes and French fries. Lifestyle modification. We have to have a healthy diet, exercise, and take care of yourselves. Like, you have to take care of yourself. There's only one you, and your family depends on you being there. So.
Thank you so much. That was very, very well summarized.
Okay.
Dr. Sharee Wright, thank you so much for joining me today. And I hope we didn't talk about a big disease, which is aortic aneurysms. We'll talk about that in a different episode. But thank you so much.
Come back for that. Okay.
All right.
Thank you.
Thank you so much for listening. If you found us valuable, you can subscribe to the show on Apple Podcasts, Spotify, or any of your favorite podcast app. And also, please consider leaving us a rating or a review, as that helps others find the podcast too. I hope you have a great week ahead.